Hello, everybody. Before I begin, I'd like to thank a few people. A lot of effort goes into organizing something like this, particularly an event like this with a live demonstration. We've tried our best. So far, no glitches, and I hope we won't have any. Particularly, I'd like to thank some of my younger doctors in our department who've toiled very hard, particularly Christy Chung, Peggy Lee, Belinda Wong, and Dr. Michelle Chung. Also like to thank the members of our department who've contributed in their own way, particularly Connie Ko. She's really worked very hard for this event to collate all the names, and some of you have been in contact with her. The Department of Orthopedics and Traumatology for having offered us the time and the patience for which we are going to use today during the live demonstration. The nursing officers in the operating theater. Some of the resources for this symposium today, particularly the equipment and the hospitality, have been offered by Sonosite and Ultronics. Thank you, Doxy. Thank you, KM. And to you all for coming here and making this event hopefully a big success. Now, coming to the issues of ultrasound, bats, and ships, we've talked, and you've heard from James and PT so far. They've really moved into our operating lists. This has become possible because of recent developments in the ultrasound technology, miniaturization of machines, improvement in probes, and therefore, now we are having this technology in our operating theater, and therefore increasing use is being published all over the world. And I hope this will stimulate interest in us in Hong Kong, and so that we can be at the cutting edge of regional anesthesia. So whenever you use some things, you always find some tips and tricks. Now, I particularly chose this title because my experience with ultrasound stems about 3 years now. Every time I went to a conference and I saw the experts speaking or demonstrating, it looked so easy. However, when I came home, I used our ultrasound machines, I found that it was not as simple as it appeared to be. You couldn't see the needle, you couldn't see the objects that you wanted to see. So eventually I found out that there are certain basic fundamentals about sonography that if you follow, it makes the job a lot easier. Now I'm going to reveal some of these secrets. Since you've come here this morning and you've taken the time and effort to come here, hopefully you can go away with some good take-home messages so that when you start doing ultrasonography in your own setup, you will find a lot of success. Now essentially what we do today in terms of ultrasound in regional anesthesia is an exercise of musculoskeletal imaging. As long as you can do a good musculoskeletal imaging in your patient, I think that's a cornerstone to your success in regional anesthesia. It's also some described, as PT alluded to before, it's an exercise of sonoanatomy. So if your mind doesn't know the anatomy, you will not see it. Now, I'm going to use a certain terms all throughout this talk, so I'd like to define a few things before we get on with further. You'll hear me saying hyperechoic, hypoechoic, and echoic. What do these mean? Basically, a hyperechoic signal means there's a strong reflection of the ultrasound. It usually represents as white dots, as for instance, the diaphragm, gallstones, etc. Hypoechoic are weaker reflections. They appear as gray dots in a gray scale. Most solid organs would appear like that. And anechoic are no reflections, which are black dots again, such as a fluid, blood, etc. So how do we, in terms of when you do musculoskeletal imaging, you need to know how to identify some of these basic structures. So I'd like to run down with some images on these. Veins usually appear anechoic. They're compressible. They're non-pulsatile, as we all know. Arteries are, however, hypoechoic, and they are pulsatile. As you know, this is very common understanding. The artery is pulsatile, and your vein is non-pulsatile and compressible. How do they appear in ultrasound imaging? Now, some of this may be very basic, but I'd like you to... Oh. There's a ghost here now. Help me. Can we have your help, please? Let's get back onto it. Sorry about this. As you can see, blood vessels, this is the scan of the infraclavicular fossa. You can see the pulsatile artery, the non-pulsatile vein. You can also use color flow Doppler to detect arteries and veins. The color doesn't really represent which structure, it represents the flow. And if you look at the scale on the top, the red usually represents the blood flowing towards the probe as opposed to the blue. You can also use pulse Doppler. You can see here the velocity curve here. And for venous, there would be no pulsatile velocity fall. The next is some fat. Fat is usually hypoechoic in the ultrasound scan. Muscles, particularly the perimysium, which is the covering of the muscle, are hyperechoic, and the muscle fibers per se are hypoechoic. Now let me just show you an ultrasound scan of the axilla, which is one of the templates that we'll be using today. This is the orientation of the probe in the short axis of the axillary artery. That means it's creating a transverse scan of the axillary artery. Look at the V, it is the reference point. In most ultrasound images, you'll have a reference point to tell you that this is the upper end of the probe. Now this is, as I said, the reference point. This reference to the upper end of the probe. This is the lower end. You can see the hyperechoic perimysium of the biceps muscle, the coracobrachialis muscle, the triceps, the humerus bone, and the axillary artery. How do nerves appear on ultrasound scan? Now, if you look at the structure of a nerve with the epineurium, endoneurium, and perineurium, they are hyperechoic. The nerve per se are hypoechoic. So if you look at a nerve, they may appear hyperechoic, they may also appear hypoechoic, or they may be a combination of both. So you may see often a honeycomb appearance where there is a hyperechoic images dotted with the hypoechoic structures. Now, as you see here, this is a musculocutaneous nerve, which is located between the coracobrachialis and the biceps, and it appears hypoechoic with some hypoechoic shadows in the middle. And this is in terms of a video scan of the axilla. You can see here the biceps, the coracobrachialis, the axillary artery, the musculocutaneous nerve, and this may be the median nerve that we're looking at. As you see, it's a very honeycombed appearance. Looking at the scan of the median nerve in the forearm, as you see here again, the median nerve is hyperechoic, located between the muscles in the forearm. A scan of the supraclavicular fossa, my colleague Dr. Kwok will deal more with it, but just to show you how the nerves appear in ultrasound scan. As you see here, this is the subclavian artery, and you can see the nerves are dotted around the top of it, the trunks and divisions of the brachial plexus. This is the clavicle, so the first rib. So this is creating an acoustic shadow, and this is in fact the hyperechoic pleura. Now, once we've identified nerve, the next structures that you often need to identify are bones, and in particular certain regions, the pleura. Because when you do an ultrasound scan, don't focus your mind only on the structure that you are interested in. You should look at the surrounding structures to give you a whole idea as to what the image is around, so that you can guide your needle to the target area. The ultrasound image of the pleura and rib can be best identified in the intercostal space. This is again in relation to the infraclavicular, so I introduced it. How do you identify the rib, pleura, and the lung? As you see here, this is the probe oriented in the long axis of creating a cross section of the rib. You can see the rib here, hyperechoic, and then it creates an acoustic shadow. The intercostal muscles, and this hyperechoic structure is the pleura, and it's often described as a lung sliding sign, the pleura. And you may see some shooting lights which is described as the lung, as the comet tail sign. It's like lights which are darting through the sky at night. So how do we get started? As James alluded to earlier, that there are different machines, there are different knobs, and we today as well. This is the Micromax system from Sonosite, which we'll be using today in our demonstration and live demonstration. Also have other machines which have different knobs, and you see it's quite confusing. Just to simplify matters, I think there are a few knobs that you need to really understand and use to start off with. First is what kind of scanning are you doing? So you need to first click on that. This is a 2D scanner, so you're doing a musculoskeletal scanning, one. Two, most machines come with preloaded setup. So they are already arranged for nerve scanning, soft part scanning, or abdominal scanning, or uterine scanning, etc. So if you select that, it makes the scan much better. Third is the resolution you need to choose. So you need to select the right probe, because now most probes are broadband. That means they have a range of frequencies that they will allow you. So you must use the appropriate frequency for the appropriate target area that you're looking at. The depth is important, to select the appropriate depth. Otherwise, you'll, as James said, you'll be focusing your image at a different area while you're scanning for a different area. And the gain. The gain button come in different shapes and sizes, but they all do the same function. So how to select a probe? Again, this has been discussed previously, the different kinds of probe, linear array, curved array. Now, depending on what you are trying to scan, if you're looking at a superficial structure, by now you should know that you want to look at something which has got a high frequency probe. So a high frequency probe will give you better resolution, but the depth of scanning will be much more superficial. Whereas you're looking at a deep structure that you need a low frequency probe, but at the same time, because it's a low frequency probe, your resolution is not that clear. So this will determine what probe you need to choose for your scan in. Now there are a few terms that I like to introduce again. What is the axis of scan that you normally do? One is the short axis scan, which is a transverse scan or cross-sectional scan, and because, as you can see here, the ultrasound probe is creating a cross-section of the needle, so it's a cross-sectional scan of the target. And because you're introducing the needle in the short axis, you'll only see part of it, and it is out of plane. So the needle is being advanced not in plane. The plane of the ultrasound scan is in the other axis. So this is called the short axis scan. In contrast, you have the long axis scan, a longitudinal in-plane scan, where the needle is now advanced in plane with the ultrasound beam. Just to show you what it looks like, as you can see here, because the beam is the needle is not in plane, you'll see only a bit of the needle. Now this may not represent the tip of the needle, so you must be aware that this is only part of the needle that's within the plane of the ultrasound beam. What it looks like in the other view, this is what the needle would look like if you introduce the needle in long axis or in plane of the ultrasound. Now I needn't tell you, if you were to introduce a needle, which plane you would want to introduce so that you can see maximum definition of the needle. This is the plane that you need to introduce the needle in long axis. However, there are proponents of ultrasound guided blocks who perform these techniques in the short axis. Now, there's a phenomenon, as again it was alluded to earlier, called anisotropy. It depends on your beam being at right angles to the target that you're doing. If your beam is directed at a slightly angle, there is attenuation of the beam, so the images may not be so clear. So it's very important to direct the beam in the right orientation. Now, needle visibility is vital for success and safety. So what are the factors that affect needle visibility during ultrasound-guided regional anesthetic procedures? There's a group from Germany who've done an in vitro study. They found that the type of needle is important. Tuhi needles were better visible than the pencil point spinal needles. The diameter, the larger the diameter, the better the visibility, irrespective of the axis. As I've demonstrated to you, the needles are better visible in the long axis. The needle insertion angle, this is very important. The steeper the degree of the angle of insertion, the less visible the needle will be. And today in one of our demonstrations, I can illustrate that to you when we do the infraclavicular, because the needle is inserted at a much steeper angle. And you can imagine if the needle is inserted at a steeper angle, very little of the ultrasound beam is hitting it, and some of it are being reflected. So there's a lot of attenuation of the beam, so you may not see the needle. Insertion of a guide wire has been shown to improve the visibility of the needle. So how does the angle of needle insertion affect needle visibility? I prepared a little clip for you to just illustrate that. So does the angle of needle insertion matter? So when the needle is parallel to the ultrasound beam, as you've seen earlier, you can see most of the needle, and as you can see here, you can see some of the reflections of the needle. This is in fact the surface of the tabletop that we were using. And this is a gelatin phantom that we have created. If anybody wants a recipe, we can be very happy to offer it to you. It's cooked in our own department. This is when the needle is inserted at about 30-degree angle. Now you can see the visibility is still possible, but it becomes a little less visible than in the short axis, when the needle is parallel. When you insert a 45-degree angle, the visibility becomes even less. And when you do infraclavicular, and particularly when you want to inject the posterior cord, needle direction is often about 60 degrees or more. And that has been shown in vitro studies, and you can see in this picture itself that the images are not as clear. The needle is not as visible. Now, there are certain technical pearls. If you follow, it makes it a lot easier, and you will have better success. It's important to dim the lights of the room when performing ultrasound-guided procedures because it's on a gray scale, so sometimes bright light sometimes attenuates the images that you see. The viewing angle of some of our portable machines, they are LCD monitors, and sometimes the viewing angle can influence. So adjust the viewing angle that's best for your to see that imaging. Use your dominant hand to control the needle. I believe that's important because you need to have good control of the needle as you introduce it into the plane of the ultrasound beam. Stabilize the other hand that's holding the probe because you can imagine you can't move two things at the same time. If you move both at the same time, then you're not going to see either the needle. So if you see in this case, when we do the axillary block, the operator here has got his hands rested on the patients so that the ultrasound probe is stable, and then you just advance the needle. So move one thing at a time. Don't move both at the same time. Now, because you're using both hands, you need an assistance to inject the local anesthetic. Now, air is a poor medium for transmission, as James alluded to before. Now, air, if there is air in your medium, in your field of scan, it will deteriorate the image, it will attenuate the image, makes it worse. So try and avoid air injection. However, air can also be used as a contrast. So if you want to see the tip of your catheter, then you can inject a bit of air. Now, saline can be used as a contrast, as we will demonstrate to you today. And this is probably the first time that an exciting technology that will allow you to see in real time the spread of the local anesthetic. The more you use it, you'll soon find that how unreliable the nerve stimulator is, because when you inject, often it pushes the nerve away. The local anesthetic is somewhere, and the nerve is, has been pushed away, and that's why probably you have much delayed onset of the block. The reference point, which I have demonstrated to you, so you need to have your orientation in relation to the reference point of the probe. Use a liberal amount of gel to get away any air that may be between the probe and the patient. Use a blunt needle. We tend to use the 22-gauge 2He needle, which is single use from B. Braun, and they are fine diameter, cause less discomfort to patients. And in the beginning, I suggest that it is my recommendation to use the nerve stimulator in conjunction with ultrasound. This will provide you an element of safety. At the same time, once you develop the skill to get more visibility of the needle, then you can move on. And today I don't use the nerve stimulator for most techniques because I can see where my needle is, I can see where my needle tip is, and once you can develop that skill, then you can probably go away. It's always important to perform a scout scan. That means identify your structure that is of interest and look around in the surrounding area. So this is what I call a scout scan. Once you've found an optimal location and found an optimal scan of the area, mark the probe. This will help you from needing to repeatedly change the position of the probe. So the scout scan helps you to mark the position of the probe. Strict aseptic precautions are like any other technique. Issue that comes are how do you prepare the probe? Now, if you ask your manufacturer of your machine, they would say, yes, you can chemically sterilize it in glutaraldehyde. But I believe that some of the elements, if you look at the footprint of the ultrasound probe, it's got some soft rubberized material. I think with prolonged usage of glutaraldehyde or some of the chemical agents, it may cause some deterioration. So what we essentially do is use a camera cover, which is readily available in your operating room, and we just use some Tegaderm. I will demonstrate to you as how we do it, and it's very simple and easy to do. I don't think this is good in the long run. Do you always see all the nerves while performing? This is another question. The answer is yes. The answer is no as well. So you may not see all the nerves all the time. You may be able to identify a few of the nerves, particularly when you do infraclavicular or axillary blocks. The others become more apparent when you inject your local anesthetic. So how do we guarantee success? As PT alluded to before, this is a donut in my daughter's plate on one breakfast, and I saw it. I said, oh, I need to take that picture. Actually, if you can, if you imagine this is the artery and use the artery as your friend, because most of the neural structure follow neurovascular, follow the blood vessel. So as long as you can create a circumferential spread around the artery in question, then you should get about more than 95% success rate, as Otaki et al. From Japan have demonstrated. Now, what we tend to do when you do an infraclavicular, if you divide them into different quadrants, the posterior cord is posterior to the artery, the lateral cord is lateral to the artery, the medial cord is between the artery and the vein. And if you can create this, make the 3 injections in 3 different areas, you will see how you can create a circumferential spread around the artery. Now, before I end, I'd like to voice a word of caution. Ultrasound is surely exciting. It has changed my practice in terms of regional anesthesia, but one of the messages is what the mind doesn't know, the eyes cannot see. So you need to know these basic fundamentals, you need to know the basic anatomy of the area. There's a learning curve. Learning curve depends how many hours you are prepared to put in. It doesn't need to be in patience. You could sit in a corner, get a hold of a machine, scan yourself, scan your friend, scan your phantoms. And this is how you develop the skill and dexterity to control needles, be able to visualize the needle, and in real time guide your needle to the area under consideration. Here you can see one of our doctors spending our time trying to guide a needle and in plane. So you may have to sit hours and then sometimes to try and get this into your armamentarium. Take small steps. Today you may go back and think this is exciting technology, but I would suggest you take small steps. It takes time, but be patient. Don't be impatient. Because there can be serious complications. So you need to see, get supervision, or attend some courses so that you can improve that on your skills. Serious complication, as PT referred to, you can impale some of the nerves, particularly areas where there are bone. You will see in structures where there are no bone, like the infraclavicular area, the blunt needle actually pushes the nerve away. But whenever there is a bone, like in the inguinal region, femoral triangle, it is possible to impale the nerve. So one needs to be careful. I'd like to conclude here by leaving with this picture from Cape Town in the Stellenbosch wine area. Thank you.